Hi everyone, welcome back to this channel. This is Dr. Sam, and today we are going to talk about some endo questions or endodontic questions for INBDE. So in this video, I will be explaining the main answer as well as the rest options in order to clarify some really good concepts. So make sure you listen to the explanations as well, because these explanations can be used to answer a lot of other questions which are not included in this as well. So let's get started. So the first question for today is, when you are doing a vital pulpotomy, that means tooth is vital, pulpotomy, that means only half of the pulp tissue is removed on a young immature permanent tooth. So we have to remember that it is still immature and it is a permanent tooth. You notice some hemorrhage after pulp amputation. So after the pulpotomy, you're still seeing some bleeding, and it could not be controlled even after using multiple cotton pellets for several minutes. What would you consider your next step to complete this treatment? So they are just asking the next step, not the whole process. So which means this goes out of the picture, because you cannot have all, even if you find multiple things, you cannot select multiple things because they're just asking of the next step. Can you just stop the procedure and close the tooth with an interim restoration? Obviously not, because see here, you can see hemorrhage after the pulp amputation or the pulpotomy, and hemorrhage essentially is a sign of inflamed pulpal tissue. If you closed the tooth with an interim restoration at this point, then the patient will come back in a couple of days or a few days with pain. They may have swelling, and there'll be problems. So you're not going to do this one. So this option goes out of that. Then perform the amputation at a more apical level. This is a better option, and let me explain to you what this is. Basically is that, let's say this is our tooth, the crown of the incisor, and this is the root which is not completely formed. This is our pulp area, and the infection is, let's say it started from the coronal part and the infection reached the pulp, and now this part of the pulp tissue is all infected. Okay, so what they're saying is that you do a pulpotomy and remove this part and remove this part up till here, and when you do it up till here, you're still feeling some hemorrhage. So in the second option, they're saying perform the amputation a little bit lower, like you include this amount and you remove this part of the pulpal tissue also, and you reach a uninfected part of the pulpal tissue. Yes, this is a better option, because you're reaching the uninfected part of the pulpal tissue here, and you're still keeping the rest of this pulp vital inside the canal. So the second option is much better. Apply formocresol with cotton pellets at the amputation site. Please do not do this. Formocresol has a lot of side effects, and we do not use these nowadays. This is also a good option of control the hemorrhage with hemostatic agents. Now back to the diagram here. When you come at this point, and if you still don't get the bleeding to stop, that's when you apply hemostatic agents. So this would be after you've completed the amputation in a more apical level. So this would be the step after this. So it's still not the next step, so we're not going to select that one. And irrigate the canal with sodium hypochlorite, then apply calcium hydroxide. Well, out here we are not doing the full root canal treatment, so we are not going to use sodium hypochlorite in the canal, okay? Because sodium hypochlorite has this effervescent action which actually dislodges the pulp from the canal. We don't want to remove the rest of the pulp, so we're not going to do this option as well. So our answer is perform the amputation at a more apical level. Let's go to the next question. The patient presents to you with pain in one of the tooth on chewing, okay, pain on chewing, and the patient has normal gum health. There is no restoration or caries seen clinically as well as radiographically, but you see pulpal pathosis, What do you think is the diagnosis of the tooth? First of all, when you see this line like no restoration or caries seen, this option gets cancelled, because for condensing osteitis, you need to see a huge restoration or a caries close by because of low grade infection on the tooth area. So condensing osteitis is not going to happen. It is not going to be a periodontal abscess either, because they say that they have normal gum health. So not periodontal abscess. Will it be secondary occlusal trauma or will it be a vertical fracture of tooth? The answer, I would say, is vertical fracture of tooth is more like the option which you should be choosing, because they are asking for the diagnosis of the tooth. Diagnosis will be vertical fracture of the tooth. Secondary occlusal trauma is one of the causes for that. Now, a vertical fracture of the tooth, for this one, usually you can find this by asking the patient to bite on a tooth sleuth or a bite stick. It is usually quite hard to see on radiographs, but you would notice that most of the areas have a good periodontal condition, and suddenly there is a huge isolated pocket in the fracture site in a fractured tooth area. Okay, so you see these like J-shaped kind of radiolucency. The tooth would typically need an extraction in this situation. Alright, so even though this is the correct option too, it is not the diagnosis. Answer is vertical fracture. So let's go to the next question, which is, during a routine radiographic exam, you see bone loss extending from the CEJ to the apex of the tooth number 30. This is routine. That means the patient probably did not notice that something was going on. That means it is asymptomatic. You see bone loss extending from the CEJ to the apex of the tooth. CEJ to apex. Okay. Probing depths are above normal limits all around the tooth. So probing depths are normal. However, at one point, the probe drops suddenly to an even greater depth. The vitality test is negative. This is a very important line. Vitality is negative. What do you think this patient would require? Now, when you read this question, you might remember the root fracture and the periodontal situation from the last question, right? Because suddenly, your probe drops to a greater depth when the rest of the probing depths are normal. But here, this line is important. The vitality test is negative. Now, vitality basically means that the blood flow and the nerve supply to the tooth is good. When does the vitality become negative? It becomes negative when the tooth is dead. When there is a problem with the blood flow and the nerve supply, and that occurs when there is infection. So we have established that this tooth, the root canal of this tooth, is infected. So in case of an infection, you are going to need endodontic treatment, right? Now look at these options: endodontic treatment only, root end surgery, extensive periodontal treatment followed by vitality reassessment, periodontal therapy followed by endodontic therapy, endodontic therapy followed by periodontal therapy. Now when you see options like these, you go and check for what is the bone loss pointing to and what is the perio condition pointing to. The bone loss is extending from the CEJ to the apex of root number 30. Now when it is from the CEJ, that means there is a periodontal involvement. When the bone loss is from the apical area, then there is endo involvement. In this patient, other probing depths are normal. So it is not a perio-endo lesion, but rather a endo-perio lesion. So since it's an endo-perio lesion, you would need to treat the endo first, okay? And then treat by the periodontic treatment. So the answer for this question is actually this, okay? And not just endodontic treatment. Alright, so next go to the next question. In this one, patient presented to the clinic and during routine exams, you found altered root canal. Again, routine exams, that means the patient was probably asymptomatic. You found altered root canal with increased size of the canal of the anterior tooth. Canal is probably getting wider, or that's what they're saying. The patient has a history of falling on her face. That means she has a history of trauma. The radiolucent lesion in the canal space does not move when radiographs are taken from different angles. It is a radiolucent lesion. Radiolucent inside the canal definitely says that there is some internal problem going on. Could it be external resorption? No, obviously it's internal problem. It will most likely be internal resorption. Now the last line is basically the slob technique, same lingual opposite buccal. If something was on the outside, it would move. If something is on the inside, it is most likely that it would not move. So this is what the answer is, internal resorption. Now let's go to the next question. When the vitality test is positive, which of the following do not need endodontic treatment? Select all that apply. When you look at all of these options, cementoma, abscess, granuloma, cyst, scar, bone cyst, globular maxillary cyst. When I look at these straight up, I find traumatic bone cyst, globular maxillary cyst. These are things happening in the bone and it's not affecting my teeth. So obviously they are not going to need endodontic treatment. Which of the following do not need endodontic treatment? That's what the question is asking about. So yes, these two will obviously not need any endodontic treatment. Whereas cementomas, occurs most frequently in the anterior region of the mandible. It starts as a radiolucent area and then it calcifies. It can also be called as a periapical cemental dysplasia. So cementoma is also in the bone. You do not need any endodontic treatment for the teeth. Rest of these ones do need endodontic treatment. Chronic dental abscess is often a result of periapical granuloma. There will be a radiolucent area at the apex of non-vital tooth, and the fistula is often found leading from an abscess cavity, and once the drainage is established, the tooth stops being painful, right? Chronic periapical abscess often give rise to a sinus tract in the gingival tissues. Now chronic periapical granuloma is most common sequelae of pulpitis. It is asymptomatic and it is associated with a non-vital tooth. So this is non-vital, this is non-vital, but vitality is positive. I'm just explaining the rest because you need to remember that even here a radicular cyst is, what is it? It is basically a radiolucency at the apex of a non-vital tooth. Okay. Then what is the apical scar? It is basically a scar tissue which is formed after healing. Once you've done the endo treatment, if there was a abscess, granuloma or cyst below a tooth at the apex of the tooth, and then you do a root canal treatment, then whatever is remaining, when it is still healing, that's what is called as the apical scar. So all of these are related to non-vital teeth, whereas cementoma, traumatic bone cyst and globular maxillary cyst are related to vital teeth. So even though it was an easy one, I just explained the rest of the answers for you. Now let's go to the next question. Patient presents to your clinic with periods of spontaneous, unprovoked, continuous pain on the lower left side. Pain lingers after removal of the irritant. Lingering pain. Patient is unable to point out the tooth. This is most common. Patient can't point out the tooth because the whole of the lower left side is hurting. The radiograph shows no periapical pathology. Now this is tricky because you don't see a periapical pathology on the lower left side, but the patient is in severe pain. How will you diagnose and treat the tooth in question? First of all, how will you identify? One way to do it is check the vitality of the teeth. Okay, when it is hurting so much, there's a good chance that the pain threshold on that tooth would be different. The vitality of that tooth might be lost. Okay, so check vitality on the left side on a virgin tooth first. Yes, so this is a good option. You will check that. Select all that apply again. So check the vitality of the tooth. First start with the virgin tooth always and then check the other one. Always check the probing depth, because from the earlier question you remember that suddenly if you have a fractured tooth, it would also hurt on chewing, but it would not be like a continuous pain. It would only be a sudden pain when you're chewing. So, and you would also know which tooth it is if you notice that probing difference, sudden probing difference. So probing depths are important. so as to remove fractured tooth as the possibility. Then check with percussion and palpation. Most probably this will give you the area which has the problem tooth, or do palpation and percussion. When you percuss from the top of the tooth, you're not banging like you're banging a nail in a wall, but gently percussing. The tooth which is in question will hurt more. Palpation, usually lateral palpation, is good for knowing if there's a abscess, or sometimes even perio problems can be easier to diagnose when you palpate on the lateral side of the gums. And then, would you need to treat this with a root canal therapy? Yes, it sounds like it is irreversible pulpitis because the pain lingers after the removal of the irritant. Once you do all of these tests, vitality tests and the probing dabs and percussion palpation along with the x-rays, most often that tooth will probably have a big carious lesion or restoration. And you would know which tooth it is. Obviously not reversible pulpitis, obviously not a sedative filling or a new restoration with a base. Not happening. You're going to do the upper 5 options. Alright, so next, let's go to the next question. A 7-year-old girl comes to the clinic with a complaint that tooth number 9 is draining pus in her mouth, upper front tooth, draining pus in her mouth. She has had a history of trauma. Vitality test shows no response. Vitality is negative. What is the treatment? Obviously it is a 7-year-old girl. History of trauma, maybe it was treated with a filling or whatever, and the tooth is dead. What will you do? First option, it is only necessary to give the child analgesics and antibiotics for pain and infection. Obviously not. Analgesics and antibiotics are not going to do anything unless you're just planning to send this patient to an endodontist and you're buying time. I wouldn't do this. I would just open that tooth up, okay? Now, obviously, it's a 7-year-old patient, so that tooth has not completely formed yet. The apex is still open. So the first thing you might start with is, what is apexogenesis? Since number 9 still has an open apex, you can start with apexogenesis. It's similar to the first question, and I'm going to explain you apexogenesis and apexification in detail in this one. Apexogenesis or pulpotomy is where the pulp is still present inside the tooth. Tomy. So half of the pulp is still there. The remaining pulp will promote the growth of the rest of the root and the apex. And apexification. Fication is where there is no pulp. The pulp is basically removed and you put something inside to, stimulate the formation of hard substance at the apex of the tooth so that it closes the apex. And what do you put inside the root canal for this? For closing the apex, you put a calcium hydroxide methyl cellulose paste or an MTA paste. So the answer for this question is actually apexification, because this is a permanent tooth and it is draining pus in her mouth. It's already completely infected. So you would have to remove all of the pulpal tissue, and once all of the pulpal tissue is removed, you cannot complete the root canal therapy at that appointment. You would have to do apexification because the root apex of a 7-year-old girl for number 9 has not completely formed. So, and you cannot leave the infected pulp tissue to be in there to form the rest of the root tip. So what do? You remove all of the pulp tissue and you put some MTA, and that way it just closes the apex with a hard substance formed at the apex. Okay, obviously after the apex is closed, you would have to follow it up with a root canal treatment at a later date. Okay, now let's see a different scenario. Maybe it's a 12-year-old patient. Okay, and in that case, if it's a 12-year-old patient coming to you with a draining pus in her mouth, then you would have to do a full root canal treatment for that patient. At that time, you do not need to put MTA or anything. You can just straight away go ahead and clean and shape the canals and see how it's reacting and finish off the root canal treatment like any regular adult tooth. Obviously, you will not be doing extraction because like a 7-year-old patient, you cannot be extracting a front tooth. For most people, in fact, you can't be extracting front teeth unless it's absolutely necessary. Periodontal surgery to remove the sinus tract is not going to do anything because the cause of the problem is infected pulp. The right option is apexification. Okay, what is the treatment? First is apexification and then comes root canal treatment. So the next question, what is the difference between a chronic apical abscess and a periapical cyst or granuloma radiographically? Chronic apical abscess is asymptomatic. The chronic apical abscess is sometimes so painless that it may go undetected for years until it is revealed on an X-ray. So chronic apical abscess can be asymptomatic or can be symptomatic. Okay, so this is not differentiating factor between abscess and a cyst or granuloma. Only histological examination can differentiate. Yes, this is true. Histological examination can definitely differentiate between a cyst, abscess, granuloma, whatever it is, but they are asking you, how do you differentiate radiographically? And the easiest answer is the border of the radiolucent lesion. An abscess will have a radiolucent border, whereas a cyst or a periapical granuloma will have a radio-opaque border under the root. Let's go to the next question. A 50-year-old patient comes to your office. Your assistant takes radiographs and you notice a periapical abscess on tooth number 3. Periapical, and you do some tests. Which of the following tests will be negative? When you have a periapical abscess, the tooth is basically dead. So your electric pulp test will be negative because tooth is not vital. Cold test will be negative. At this point, sometimes a heat test might be positive. A water test is just not, there's no test like that. They're just playing with our minds for this one. Then the last question. In a cone shift technique, when the vertical or the horizontal angulations of the X-ray tube head changes, the object buccal or closest to the tube head moves on which side of the radiograph when compared to the lingual object? Remember the slob rule. Same lingual, opposite buccal. Object buccal or closest is going to be opposite. So the answer is opposite. And that's all, my friends. If you have any questions or doubts, please let me know in the comment section below and I will be happy to answer them. Hope you like these videos and solve them together with your friends so that you can discuss together. Adios for now. See you next time.